11 o'clock, 11 o'clock, fine, sir. Recording
11.
started.
So we'll start.
Yes, sir.
Justin, I'll start. Huh?
Yes, sir. Please, sir.
Okay. It's my great pleasure to welcome all of you to the 16th edition of the Clinical Neurology Forum, where interesting cases are presented from all over Tamil Nadu from various institutions, and we try to educate and enlighten ourselves with the discussions. I am thankful to Professor Justin for having agreed to chair this session. Professor Justin is the Professor of Neurology at Madurai Medical College and an eminent neurologist of Madurai. I am also doubly pleased that this time we have the Institute of Neurology presenting cases, and I am thankful and grateful to the Director, Professor Lakshmi Narasimhan, and Professor Shanmu Sundaram for having joined and allowed their cases to be presented. Their cases will be presented by Dr. Nirmal Kumar and Dr. Sujaya. Now I'll hand you over to the chairperson, Professor Justin, who will conduct the proceedings from here on. Professor Justin, please take over.
Thank you, sir. At the outset, I thank Professor Natarajan sir for inviting me to chair this webinar section. My mentor, he has pleased me so many times, and he has guided me so many times to carry my particular things in my life as well as in my academics. Thank you, Professor Natarajan sir.
Thank you, Ian. You can carry on. Thank you, Justin. You can carry on.
I invite the moderator, Professor Lakshmi Narasimhan sir, is my close friend, my senior, and a director of Institute of Neurology, to moderate this session. And also I welcome Dr. Shanmu Sundaram, my friend, who is an assistant professor of neurology at Madras Medical College, to moderate this session. I request Dr. Lakshmi Narasimhan sir to say a few words about this program.
Sir, I thank Professor VN for giving this elite opportunity to the Institute of Neurology. Without wasting much time, I request the first postgraduate, Nirmal Kumar, to present the case, just a routine clinical exercise. And I request Nirmal to start the presentation.
Morning, everyone. I thank my professor, Dr. Lakshmi Narasimhan sir, for the opportunity, and I thank the panelists also for the opportunity. So I'll start presenting. So our patient is Mr. Gurumurthy, 64 years male, and he is a right-handed individual, and is currently not working. He's retired. He used to do office clerk work and is now retired. He's admitted with complaints of upper back pain and neck pain for the past 3 months. That was the presenting complaint he was admitted us with. So even prior to admission, patient was apparently normal 3 months back. Patient lifted a heavy object that resulted in pain in the neck and upper back. The pain was localized, dull aching pain, which was aggravated on lying down and was relieved by analgesics. The pain was present whenever the patient lay down and not specifically increased at night. Patient took the analgesic prescribed by a nearby practitioner and the pain got relieved. 3 weeks later, patient had a similar type of pain, but with radiation to right medial part of arm till mid-arm. The pain interfered with the sleep as it was not adequately relieved by analgesics this time. The pain also interfered with day-to-day activities. So he came to us with these complaints. So for the events post-admission, first 3 days during admission, patient was ambulant and did not require any assistance to use the restroom. On 4th day, the patient developed difficulty in using right lower limb to bear weight while getting up from bed. The patient required 1 person support to walk to the restroom. And while passing urine, he had buckling of right knee and his attendees had to hold him from falling. While in supine position, the patient himself noticed that he could not move his foot normally and also could not bend his right knee. That is a right knee. The patient was unable to stand up as he had buckling of both knees on 5th day of admission. So on 3rd day, he had only right lower limb involvement. On 5th day, he had left lower limb also in the form of buckling of knees, which is both knees now. and could not lift the legs when supine and could not move both feet normally. The patient now required the support of wheelchair to use the restroom, and the attendants felt that both lower limbs were stiff to move out. Patient had difficulty in getting up from bed without support and has difficulty in turning from side by side from bed. Patient is able to lift his neck from bed and is able to use his upper limbs normally. The same day, that is on the 5th day of admission, he developed benumb sensation below the nipple level and could not feel his clothes below the nipple level. The patient could not feel the temperature of water below the nipple level when he was given a sponge bath, and patient could not clearly delineate if the symptoms ascended or descended. Patient did not have any band-like pain or electric shock-like pain down the spine on bending neck. Patient did not pass stools for the past 2 days, and he had bloating of the abdomen, but there was no history of fecal incontinence. After the patient became bedridden, that is on the 5th day of admission, patient has been passing urine every 30 to 45 minutes. He had difficulty in initiating a stream of urine. Every time he passes only small quantities of urine and had a sense of incomplete emptying. The patient was subsequently catheterized as he had frequent changes of diaper. There is no history of urge incontinence. Patient had a history of loss of weight for the past 3 months. Patient had 2 days of fever after admission, which was intermittent, associated with chills and rigor. There was no history of cough, burning, micturition, and loose stools. Patient still had a back pain of similar quality and requires analgesic frequently. As far as negative history is concerned, there is no history of thinning of limbs, twitching of muscles, no history of diurnal variation of weakness or fatigability, no history of any muscle enlargement, cramps, or pain, no cranial nerve symptoms in the form of diplopia, facial lag, dysphagia, or nasal regurgitation of feet. No history of postural giddiness or abnormal sweating, no history of swaying while walking, no history of tremor involuntary movements, no history of postural giddiness, abnormal sweating. Past history, there is not known diabetic, hypertensive, thyroid, heart disease. A patient had a history of alopecia totalis after he had a febrile episode about 5 years back, diagnosed as probably catagen effluvium. Personal history, he's a smoker. He smokes about 1 pack per day for the past 40 years. And he is an occasional alcoholic. There's no significant family history or no significant tuberculosis history in his family members. To summarize the history, 64-year-old gentleman, chronic smoker, presented with insidious onset progressive neurological illness which started as upper back pain with radiation to right arm for the past 3 months, with progressive symptoms in the form of stiffness of right lower limb followed by left lower limb weakness within the span of 2 days, involving both proximal and distal muscles. Sensory symptoms in the form of decreased touch and pain temperature and temperature perception below the nipple level, associated with autonomic symptoms in the form of constipation and increased frequency of micturition with difficulty in initiating, with no symptoms concerning cerebellum and extra-abdominal system. A significant history was that patient had 2 or 3 episodes of fever with chills post-admission. To localize history, back pain, he had a predominantly upper back pain, which is probably a vertebral pain because he had a localized pain, which is aggravated on lying down, and it's better by walking, and even started when he lifted a heavy object. And he also had a root involvement in the form of medial part of right arm, which is probably... Yes, sir.
Sorry to interrupt you. Whenever any patient, you are very specific about is a medial arm, but whatever it is with this presentation, whenever any patient comes to you, what should be your first suspicion?
Sir, I was not able to hear. The voice was breaking, sir. Sorry, sir. Can I repeat it, sir?
Any patient, is it better now?
Yes, sir. Yes, sir.
Any patient, any chronic smoker who comes to with arm pain or upper back pain in the scapulothoracic regions or in the arm pain, medial arm pain, comes to you, what should be your first thought process?
A spinal metastasis causing the root pain, sir. Vertebral and root pain, sir.
It's so
Anything more than
specific.
Anything more than that?
Is there any mass you have to suspect involving the brachial plexus?
Any tumor you should suspect strongly?
Small cell carcinoma along with metastasis to
What
brachial
do you call that?
pan costume.
Yeah. And did the negative history honors at the presentation?
Voice breaking, sir. Sorry, sir.
Any negative history for honors at that presentation?
He didn't give any particular history
No,
concerning
it
those.
must be specific. In
Yes,
any
sir.
pain, superior sulcus tumors of different etiologies can present as upper arm pain. Okay.
Okay, sir.
Any smoker of 40 years pain of arm pain, you should keep that in the back of your mind. Continue.
Okay, sir. Yes, sir. So this is probably vertebral pain with the T1, T2 root involvement. Since he had localized pain with aggravation lying down and even started post lifting of a heavy object. Weakness, the localization is corticospinal tract above T6 and below T8. I say so because it's a stiff type of weakness, so it's a human type of weakness. And there is involvement of lower limbs, trunk flexors, and abdominal muscles. So up to T6 level is involved, but there is no upper limb involvement. So the level is above T6, but below C8. Sensory symptoms, he had the localization is spinothalamic tract and posterior column at T4 level, which is because he had a benign sensation with inability to perceive the temperature of water below the nipple level. Nipple level is T4 level. So presence of definitive level reasserts the involvement of spinal cord. Autonomic symptoms, he had bladder symptoms and bowel symptoms after he had a weakness. So it didn't precede the weakness. And the localizations between suprasacral and infrapontine region, which is because the urinary symptoms, he had both storage symptoms and voiding symptoms. Storage symptoms in the form of he had a hesitancy, storage symptoms in the form of frequency of urination, and voiding symptoms in the form of a difficulty in initiating a stream of urine. And there was no fecal incontinence, so it's probably a supraconal bowel involvement.
Nirmal Kumar, one question at this point of time.
Yes,
He
sir.
was catheterized. How much of urine was collected when he was catheterized?
So only a small amount of urine, sir. 100 to 200 ml was collected, sir.
Okay, thank you.
Yes, sir. So etiological localization based on history. So features suggest to it's probably extradural extramedullary compressed lesion. I say so because it's an insidious onset, progressive neurological illness. Onset was with localized back pain, which was asymmetric in onset, and there was associated radicular findings. So these two findings probably point out to a etiology of extradural extramedullary compressive lesion.
What are the various different types of pain we encounter in neurological conditions? Nirmal.
Sir, yes, sir. It could be a vertebral pain, it could be a radicular pain, it could be a funicular pain, sir. Vertebral pain is usually.
Yeah, tell me.
Yes, sir. Vertebral pain is localized pain, and it is usually aggravated on lying down, and it is not radiating usually. Radicular pain has a radiation to radical and the shock-like sensation under with paresthesias, and usually involve the limbs, upper limbs commonly, and it's aggravated on coughing, and whenever the pressure increases, the transmitter increases in coughing. Whereas the funicular pain is poorly localized pain, present. It may be present throughout the spine. It's poorly localized, and it is usually suggestive of intramedullary lesions.
Nirmal, this
Yes, sir.
radicular pain is sudden sharp radiating pain, which is along the dermatomal pattern, which is aggravated by coughing, sneezing, or any maneuvers which increases the intraspinal pressure, which has gotten reproducible quality.
Okay, sir.
The funicular pain is dysesthetic pain. It means that it has involved the tracts, intramedullary tracts. Okay.
Okay, sir.
Right. At this level, what is the horizontal level? What is the vertical extent of this? It is a spinal cord lesion.
Yes, sir.
What is the horizontal level? What is the vertical level at this juncture?
Sir, as far as the vertical level is concerned, the motor level is above T6, below C8, sir. Because he had a weakness of lower limbs, trunk flexors also were involved, sir. So lower level is.
So actually, Nirmal,
Yes, sir.
normally in spinal cord, you should always take the highest level of lesion.
Okay, sir. So highest level could be C8, sir, because he didn't have any upper limb involvement as per history, sir.
You
Yes.
should say that radicular involvement at C8T1 and then cord involvement that's how you should present.
Okay, sir.
See, the highest level should be vertical. When you are talking about the vertical thing, whatever the highest level of involvement, then that will give the viewer an idea about what is the extent of the lesion. Okay.
Okay, sir. Okay, sir.
It need not have involved the cord at that level,
Okay, sir.
but it has involved the radicals.
Yes, sir.
Radicals. Now tell.
So since patient had a medial arm involvement, which is T1 radical, T2 radical, so that is probably the highest level, because the sensory level, spinothalamic tract, it is the level of nipples. So both corticospinal and spinothalamic and posterior column is level of nipples. So highest level in this patient is probably at T1, T2 level.
Yes.
And horizontal extent, the patient has involvement of corticospinal tract, posterior column, and spinothalamic tract. So, and reticulospinal fibers in the form of bladder involvement also. So it's probably almost a complete involvement of the spinal cord from
What did you
horizontally.
say? Hey, what did you say about the bladder fibers? Tell me again.
Sir, reticulospinal fibers, sir. Pontine reticulospinal fibers, which go to the sacral.
No. I tell you, the bladder fibers, the traveling of the bladder fibers from the Barrington's nucleus to the sacral, the pathways is not definite that it is pontine reticulospinal. Do you understand?
Okay, sir.
Reticulospinal is a completely different tract carrying a different information.
Okay,
This
sir.
autonomic fibers, descending autonomic fibers traverse completely differently.
Okay,
Do you have any reference that it traverses in the pontine reticulospinal?
sir. Not sure, sir. I'll refer again, sir. I'm not sure, sir.
Please. I don't think so, because the descending autonomic fibers traverse very close to the spinal canal.
Central. Yes, sir.
That's why it is very close adjacent to the spinal canal. They are a separate entity.
Okay, sir.
They don't mix up with them. The reticulospinal has a different function altogether. They got nothing to do with the autonomic system. Continue.
Okay, sir.
Nirmal,
Yes, sir.
he had neck pain, isn't it?
Transiently, after lifting of objects, he had neck pain, sir, but it got resolved.
That's
After
right.
taking
That's right. But,
Yes, sir.
but he did
Yes,
have neck pain. Coming back
Yes,
to
sir.
what Professor Ellen said, when you talk of the highest level, you should take the symptom also into consideration. He did have neck
Okay.
pain. He also had pain in the upper limb. So based on the symptoms, the highest level would be cervical.
Definitely.
sir.
That's what I say. The highest level is C8, sir. He had what I saw in the C8.
And how
Okay.
is it that you came to the conclusion it is a compressive lesion?
Sir, because of the asymmetric onset of symptoms, sir, and the all symptoms mainly started after lifting of the object. The patient's pain complaints back pain initially for 3 months, sir. So
So it is an
compressive
acute,
etiology is more.
1 minute, Nirmal, it's an acute on chronic
Yes, sir.
presentation. Am I right?
Yes, sir. Yes, sir.
3
Yes,
months
sir.
duration of pain, back pain, which was not necessarily a neck pain, and subsequently an acute onset of neck pain with the deficit evolving over a period of 6 to 7 days.
Yes, sir.
Okay.
Yes,
So
sir.
it's an acute on chronic.
Yes, sir.
Okay.
It has gotten sequential involvement. Nirmal.
Yes, sir. Initially, the corticospinal tracts were involved, sir. Of the right, then the left was involved, sir. Then sensory symptoms started, sir. Sensory symptoms attained the maximal within the same day, 1 day itself, sir. And there is no ascending or descending pattern of the sensory involvement, sir. So based on that, I'm not able to tell if it's intramedullary or extramedullary, sir. But the lesion had a sequential involvement, sir. That is there, sir.
That is there. How to differentiate between the intramedullary and extramedullary lesion?
Sir, in this patient, there is more of a human symptoms than the spasticity. The stiffness was the main symptom, sir. So human, I mean, the extramedullary lesions tend to have more of a human symptoms and signs, whereas intramedullary lesion tends to have a more element symptoms and signs, sir. And bladder involvement in this patient occurred after the patient had a weakness, entire weakness, sir. So that is also suggestive of an extramedullary lesion, sir. And asymmetricity in onset is also suggestive of an extramedullary lesion, sir.
See, the whole evolution of the whole neurological illness deficit was only 3 to 4 days,
Yes, sir.
or 4 days or 5 days.
Yes, sir.
And within that period, he had both the sphincters involved.
Yes, sir.
So it's an early sphincter involvement.
Yes, sir.
Yes. So it goes
Yeah.
with along with the involvement of other structures in the spinal cord.
Yes, sir.
So, and that was why I was asking you, how did you come to the conclusion that it was probably a compressive lesion? Can you certainly say it's a compressive lesion? The evolution
only-
seems to be more in favor of a
An
myelin
interim-
fix.
Yeah, Nirmal,
Yes, sir.
Nirmal, in
Yes,
the
sir.
timeline, initially, it literally followed the lamination of the corticospinal tract. No, it initially started with the
Weakness.
weakness of where? Where does the weakness? Weakness was in the distal leg. All these things happened right in front of our in the ward.
Yes, sir. It happened in the ward, sir.
Weakness is right in front of. What is the first one to start with?
Buckling of right knee.
Yes, sir.
No,
He couldn't
no, sir.
stand.
No. First is the foot, sir. Leg.
No, what he
The-
presented was right lower limb weakness at knee. And then when he was when he was lying down, he had difficulty in movement of the foot and also bend at the knee. That's what he presented.
So actually, both occurred simultaneously.
And then buckling of both knees. Yeah, it was so quick. I agree with you. All within the 2 days.
Sir, the initial weakness was noticed in the ankle and the knee, sir. That was the first
Okay,
presentation.
agreed.
So-
Okay, if you say so,
So
that's
that
fine.
means the lesion is far out in the lamination, and subsequently it ascended. See, there's in a span of day 1, day 2, day 3, he completely became paraplegic.
Paraplegic.
And tracks also involved one by one, and all right in front of us.
Yeah.
That's what happens, sir.
Continue, Nirmal, whatever.
Yes, sir.
Please continue.
So differential at this point can include because he's a chronic smoker and he has lost weight recently. So, and considering he had a sequential movement of the tracks, probably extramedullary compression. Pot spine could be the first DD with the spinal, and he had a fever also post admission, sir. So it could favor a pot spine, but second DD is also spinal meds with epidural collection.
How long did the fever last?
2 days.
2 to 3 days, sir. Then we started
Ah.
antibiotics, it subsided, sir.
Yeah, it's a short duration fever. Started after your catheterization.
After
Even though you
catheterization.
said there are no dysuric symptoms, it started following catheterization.
Yes.
It
So
might
it is-
have something to do with the urinary tract.
Yes.
Okay, sir.
Rather
It
than
knows-
considering a pot spine, I mean, fever as an indication of a pot spine.
Okay, sir.
Nirmal, it is very safe to say, it's at present categorically saying, instead of saying the extramedullary, so keep both options the history level.
Okay, sir.
Okay.
Okay,
Right.
As Professor
Yes,
Pillian said, you know that it is a myelopathy. It is very acute onset myelopathy with some chronic symptoms which are lasting for 3 months, which over the span of 5 days, it has completely involved horizontally the entire spinal cord. So what Sir said, you should always keep the myelopathy as myelitis also as an option.
Okay, sir.
Nirmal,
Yes, sir.
You don't know, after the examination it might change, but at this point of time, keep it open. Keep both
Okay.
options.
Nirmal, what are all the condition in which the pain is aggravated while lying down?
Excellent question. Excellent question, Justin.
Yes,
I
sir.
wanted to ask
So
that.
we had-
Yeah.
Any
Yeah, think
diurnal
of-
variations, Nirmal, diurnal
sir.
variation, and that is also important. You must.
Yes, sir. There is no
explain
diurnal
your
variation. I
history.
pointed that out, sir. There's no diurnal variation, sir. It was present whenever he lay down, sir. Not necessarily in the night or day. The pain was.
Yeah, what are all the
that's it.
condition in which you will have a aggravation of pain during the lying down position?
So that's the case. We have to consider inflammatory or traumatic or metastatic back pain, sir. So mechanical cause of back pain has to be considered because
Yeah.
inflammatory is more likely in that scenario. Inflammatory bar metastasis.
So it's very simple. Trauma, fracture spine, or TB spine, or secondary spine, or spondyloarthropathy of in younger age group, spondyloarthropathy. These are all the important epidural abscess, wherein which
Yes.
you will not able to lie down because of the pain. And
Yes,
lastly, we have to add the cardiac failure also. You may not be able to lie down. Okay.
Okay, sir.
importance is it makes it unlikely that this is due to a disc disease.
Yes.
Yes, sir.
That is the
Yes.
importance. You will have
That
to
is
consider
important.
other possibilities when the pain is aggravated on the lying position. Continue.
Go ahead, go ahead.
Yes, sir. So in more the examination, he was conscious oriented, moderately built and moderately nourished, no pallor, icterus, cyanosis, clubbing, or lymphadenopathy. He didn't have any clubbing, and he had no neurovenous marker, peripheral thickening. He had alopecia totalis of the scalp. Vitals were normal only. Respiratory rate was 16 per minute. Thoracoabdominal, no paradoxes. Higher mental function was conscious, oriented to time, place, and person. Attention was normal, and MMSE was 30 by 30, and there was no higher mental function disturbance screening. So cranial nerves, second cranial nerve, we had a 20 by 20 vision on the right side and 20 by 25 vision on the left side. Fundus was normal. Extraocular movements were full, and his pupil were reacting, and saccades, pursuits were normal. Light reflex was also seen, and no RAPD was observed. Facial sensation also normal. Motor part of fifth now, jaw, clenching of mouth was also normal. Jaw jerk was absent. On cranial nerve 7 examination, there was no difficulty in wrinkling forehead, and there was no deviation of angle of mouth. Air conduction was better than bone conduction. Rennes was positive, and the rebus was central and not lateralized. And uvula was central. Gag was normally present. Shrugging of shoulders was also normal. Cranial nerve 12, there is no tongue deviation or tongue wasting fibrillations. More in the motor system examination. Bulk was 27 in the bilaterally, 23 in the right forearm, 22 in the left forearm. Thigh bulk was 45 bilaterally. Calf bulk was 35 bilaterally. He had lower limb flaccidity, but with normal tone in the upper limbs. So, power examination. He had a trunk flexion weakness. He could not get up from the bed without holding the bed. That suggests a grade 0 to 2 trunk weakness. Upper limb power was normal. Hand grip was strong. Neck power also was normal. These findings are documented on day 3 of admission. That is when he started to have a right lower limb weakness. Hip power, abduction, adduction, flexion, external rotation, internal rotation, everything was 2 on the right side and was 5 on the left side. Knee extension was 2 on the right side, whereas flexion was 1 on the right side. So flexion was weaker than extension. And ankle, dorsiflexion, plantar flexion was both 2. Inversion, eversion was 1. Left side it was normal power on day 3 of admission. On day 5 of admission, this is upper limb power. Upper limb power is same as previously. It was normal. Lower limb power, he had a complete paraplegia on day 5 of admission, involving all the muscles and proximal distal. The power was 0. Superficial reflexes, corneal, conjunctival, gag was present normally. Abdominal reflex were absent in all quadrants. And I just want to point, there's no BO sign was not present. It was not, BO sign was not seen, sir. And plantar sections are bilaterally. Anal reflex and bulbocavernous reflex was present. DTR examination. On right side, jaw jerk, deep facial reflex was absent, and bicep, supinator, tricep, finger flexor were absent on the right side, whereas on the left side it was 2+. Finger flexor was absent on the left side. Lower limbs, knee jerk and ankle jerk was bilaterally 3+. There was cross adductor reflex was observed, and there was an ill-sustained ankle clonus was observed. So the summary of this is the right side upper limb reflexes were absent. So sensory system, pain, temperature, fine touch was decreased up to T4 level. Vibration was absent in bilateral first metatarsophalangeal joint, medial malleolus until the ASIS. Spinal vibration was absent till the D8 vertebra. About 8 it was normally perceived. Perianal sensation was preserved. Anal tone was normal.
What about the tone in the limbs, Nirmal?
Flaccid, sir.
All 4 limbs?
Yes, sir. Flaccid, sir.
Initially,
4. Yes, sir. I'll not all 4. So lower limb, sir. Upper limb tone was normal, sir.
Okay.
Actually, on a day, initially when you had a right lower limb weakness, it was spastic, sir. Then eventually when you got the full picture, it was flaccid, sir.
Thank you.
Yes, sir. Skull spine, he had tenderness over D1, D2 vertebra. Paraspinal tenderness was present. There is no signs of meningeal irritation. Gait not be assessed. Significant finding other system examination was that on respiratory system, he had bilateral V's with grips, decreased R entry in left mammary, infraaxillary and infrascapular areas. So to summarize, after examination, patient had a bilateral lower limb flaccidity with exaggerated reflexes with ill-sustained clonus in the lower limbs. Pain temperature was not perceived below the T4 level. There is absent vibration in the lower limbs till bilateral ASIS, and spinal vibration was absent below the D8 level. Patient had preserved perianal sensation with normal anal tone, tenderness over D1, D2 vertebra. Significant findings in other systems include decreased bilateral, decreased R entry over left mammary, infrascapular and infraaxillary areas. To localize after the examination, the motor level, the highest pyramidal level was T6, but he had radicular involvement of the right C5, C6, C7, C8 radicals. So highest level of the, even though it's L11, highest level was the cervical level, which is C5. Reflex level was, highest level was T6 because he had absent abdominal reflexes, but upper limb flexus was normally present on the left side. Right side it was decreased. Sensory level, spinothalamic tract was involved at the T4 level, and posterior column was involved at the D8 level. And vertebral level was D1 because there is tenderness at that level. So this is a vertical extent. So I'll go to the horizontal extent. It's a complete, almost a complete caudal involvement, bilateral corticospinal, spinothalamic, and bilateral posterior involvement with involvement of right C5, C6, C7, C8, D1, and D2 radicals. These findings suggest a possibility of a extradural extramedullary compressive myelopathy with multi-level involvement, etiologies being port spine, spinal metastasis. Presence of left pleural effusion makes tuberculosis likely, although malignant pleural effusion with metastasis is also a possibility, especially considering a multi-level involvement. Sir.
Nirmal,
Yes, sir.
the first one, the complete cord involvement is,
Yes, sir.
you can never say with the sacral sparing.
Okay, sir.
When there is a sacral sparing, it is not complete cord involvement.
Okay, sir. So it
Even
will
in
patch.
spine, sir.
Yes, sir. Yes, sir.
Hello.
Yes, sir.
I thought, sir, Professor Ian, sir.
Anal tone also was preserved.
Normal. Anal tone is normal. Bulbocavernous is normal, and sacral sparing is there. You cannot say that it is a complete cord involvement. You say always there has some degree of sparing of the cord. So in the don't use the word complete cord involvement there.
Okay, sir.
And I told you that reticulospinal fibers for blood and
Yeah,
more,
yes, sir. Yes, sir.
They travel differs differently.
Yes, sir. Yes, sir. So shall I move to investigation, sir?
Is there any other question? Just
I have a doubt. Actually, I
Yes,
do
sir.
not know. I need a clarification. See, generally with extradural medullary, extramedullary compressive pathology, extramedullary, we expect the tone to be increased. They usually have a spastic weakness. This is an unusual situation where he has a flaccid weakness evolving within 3-4 days. Of course, there has been a collapse and it has resulted in a transverse myelopathic picture. Agreed, which can happen with spot spine. I don't deny it. Is that what you are thinking of?
In fact, in this case, the points which require to be is the buckling of knees, which again a strong pointer toward an element, and the flaccidity is again a point. Whether the whether the radicals are but the radicals they are very brisk. The reflexes are very brisk to say that it is radical, but the tone is definitely flaccid. Or is it just a spinal?
Initially, no, but later the reflexes also show changes.
Even on day 5, the lower limb reflexes were brisk, sir. The ankle and lower limb, the reflexes were brisk, and but the tone is distinctly flaccid. And they didn't go together. And the patient also clearly said that his knees were buckling on day 3 itself. So these, I really don't know how to explain. That is the exact reason why the tone and the reflexes they didn't go together as normally we say, whenever there is an hyperreflexia, the tone will be, when it did not go together. That is
The
exactly
discordance was
what-
there.
Yes, sir. And that is exactly why I wanted the elite panel to enlighten us.
No, Nirmal, ultimately all reflexes were lost, isn't it?
No, sir. Still, patient has preserved exaggerated knee jerk and ankle jerk is still
Okay.
present.
Then Ellen's point is very valid. Yeah, he has a mixture of lower motor and upper motor. In spite of a lower motor involvement, the reflexes are preserved. So there is UMN involvement causing flaccidity.
Yes, I didn't know, sir. I was not able to explain this, and that is exact. And second thing, the almost all other chords are gone, but the sacrospinal is again rechecked twice. The anal tone and the sacral, the sensations are distinctly
Preserved.
spared. Preserved, distinctly spared. Yeah. So I thought, is there any inputs which could highlight in us? That is a difficult part of this entire presentation, sir.
Justin or anybody else?
Sir, is there any involvement of associated vascular compromise because of the compression of the intramedullary, intraradicular arteries?
Yeah, even if there is a vascular compromise, the point is it all UMN or is there element and UMN? And is the element and involvement only on one side while the UMN is on both sides? But yet on both sides, the tone is flaccid. So these are the problems which we are encountering here.
Discordance.
And as he said, flaccid limbs, but with
Brisk
brisk
reflexes.
reflexes.
And both it was the findings were counter-checked twice, sir. We were not able to explain that.
No,
So,
agreed.
I think after the advent of the radiology, a lot of clinical neurology will be rewritten in the future. That's what I feel. This is one such example, sir.
Sir,
Shall I
inputs
add-
from other participants are welcome, please.
Shall I add one doubt, sir?
Yes, sir.
As you have pointed out, the combination of LMN signs and UMN signs, which we see in pediatric cases. For example, there is a condition called atonic cerebral palsy. The child will be hypotonic, atonic child. All the reflexes will be brisk. With that, we can say it is cerebral palsy. We don't call it as myopathy. So there is one way by which we can diagnose. There will be tone will be less, tone will be actually atonic, but the reflexes will be brisk. This is quite commonly seen in children. I don't know.
So that means the tone and the reflexes are not necessary to be parallel.
Yes, sir. Yes, sir. Yes, sir. And that may even give us a clue that it is a pyramidal tract. We give importance to the reflexes, brisk reflexes, rather than the tone. So we call it a cerebral palsy rather than, as the child grows, the child slowly starts developing spasticity. So we think probably it's an evolutionary process by which it comes. And slowly we diagnose it is not congenital myotonia, congenital myopathy, or anything like that. When the reflex of brisk, it is going to be a cerebral palsy. The problem, the brain is affected like that.
Yes, sir.
We still do not know.
Very invaluable input, sir. Because I was wondering whether they always should go together. But now that that children, that's a distinct entity with the flaccid tone and brisk reflexes pointing towards the corticospinal tract, that means there can be a discordance between the tone and the reflexes.
Yes, sir. Yes, sir.
One minute. Sir, Meghana sir, the
Yes, sir.
reflexes are mediated through the corticospinal tracts,
Yes.
while the tone can be affected by involvement of non-corticospinal tracts also. Is that what you are trying to say? And that could happen? Am I right?
Yes, sir. Yes, sir. Probably that's what we used to say, that the tone maintenance through the extrafusal fibers.
Yes.
And those fibers are little different from the tone which affects the tonic stretch reflex, like that.
So,
Tonic stretch reflex or different long loop reflex like that.
Sir, Professor Vian, sir.
Yes, sir.
Professor
Yes,
Vian, sir,
Ellen. Yes, Ellen.
the tone is essentially by the descending extrapyramidal rather than the
Exactly.
corticospinal. Sir.
Exactly. That's what I was trying to say. Yes.
Maybe, sir.
Yeah.
Exactly.
Yeah.
Yeah, that may be the reason. We always say that. And it is a very
So
important finding which we always feel that we are not dealing with muscular
Yeah.
dystrophy or myopathy.
We are speaking of non-corticospinal extrapyramidal tracts involvement to explain the tone.
Yes, yes, sir. Yes,
So-
sir.
So that is how the discordance has to be explained, that these they are spared.
Yes, yes, sir.
Okay.
Yes, that could be the explanation. But again, the degree of involvement is quite dense with
Yes,
regards
sir.
to all the tracks involvement.
All
being
the other
involved.
tracks, all other tracks.
Lakshmi sir,
Yes.
Vijay.
Yes, Vijayan, please. Contributions, welcome.
Yeah, yes, sir. I agree with this point that because the tone is maintained predominantly by reticulospinal, vestibulospinal tracts also. If they are spared in relativity, then maybe, yes, this point of tone
Discordance
versus.
Discordance
Now, another thing, sir, is there definite an element of radiculopathy? Because myeloradiculopathy is also a diagnosis, yeah. Or
But
is there
the
an
one thing is the reflexes were very brisk, even now.
very brisk, sir?
For radicular involvement to commit, the knee and the ankle are brisk even now. Even though the
Even
tone
now.
is very
Is there a clonus, sir? No.
Sustained
Ill
tone.
sustained.
ankle.
Ill-sustained.
Ill-sustained clonus. Okay. Okay, then I think that is the only explanation, vestibulospinal, reticulospinal tracts being spared. Apart from this, I cannot think of any other
Yes, sir.
explanation.
Thank you. I think we will move on, sir, since we have got
Please,
one more
please.
case.
Sir, one
Justin,
more point.
whatever
Is
Justin
that
says.
in
Yeah,
subacute
please,
combined
please.
degeneration, the subacute combined degeneration, the classical clinical teaching is a brisk knee, absent angle, and extensor plantar. Does that help here in any way? Because there is an element of peripheral neuropathy also. This patient did
The
not have
evolution
any.
is within days, 5 to 6 days of evolution. Rapid
Okay.
evolution.
Okay. No, just to tell the discordance, sir. Only to,
Okay.
to give another
I think
example
that-
for
Sir,
discordance.
considering this etiology, I would go for epidural abscess, which has acute and chronic presentation.
Yes, Anand.
I am thinking of epidural abscess, sir.
Okay, fine.
Yes, sir. Nirmal, can you go ahead?
Sure,
Good.
sure, sir. Good. So investigations performed were routine investigations are predominantly normal. The thing is that on CT test, because we suspected a malignancy and anyway we suspected a tuberculosis, we did a CT test. It had a mediastinal mass with left pleural effusion. And since he had constipation, we also did a CT abdomen. It had distended bowel loops. Sputum gene expert also was done. It was negative, turned out to be negative. ESR was negative, normal, sir. 2 mm per hour, normal. So this is the imaging. So there is epidural mass compressing the spinal cord at the vertebral level D1, D2, sir. So that is pointed by the arrows here. And the second finding is that there is also a collection at the lumbosacral level. Also, there is a collection in the epidural space, compressing the traversing cauda nerve roots. But clinically, patient had a normal anal tone and reflexes were brisk in the lower limbs. So that may be asymptomatic also, but that could explain the low tone in the lower limbs probably. So there's an axial cut. So in the upper cuts, you can see the epidural mass entirely encircling the cord.
Contrast
Yes,
was
sir.
given.
Sir,
Contrast was given.
contrast was not done, sir.
Right, go ahead, please.
So the report was multiple foci of altered intensities in the vertebral body, and this also showed at the multiple levels there is a vertebral body lesion, even at the D1, D2 level, and cervical level also the vertebral body itself is collapsed in multiple levels, and there's a hyperintensity, T2 hyperintensity in the vertebral body. So there's expansion soft tissue lesions in the bilateral D2 pedicle, causing the bilateral bone erosion paravertebral posterior epidural soft tissue components with epidural soft tissue measuring 3.8 into 1.7 centimeters. So final report was the epidural collection causing the compressive myelopathy with both in the dorsal and the lumbosacral vertebral involvements. So this is CT chest of the patient. So it had pleural effusion with the mediastinal widening and the mediastinal mass in the upper left upper lung, upper lobe, which is a pleural based mass predominantly. So we went ahead with the PET scan imaging to identify the extent. So there is involvement of the mediastinal nodes associated with the lung node. Lung mass also was hyperintense and hypermetabolic and PET, and vertebral body was also hypermetabolic. So the final diagnosis was a lung mass with multiple mets, with spinal mets causing the epidural collection. So we went ahead with the biopsy of the mass. So biopsy was a infiltrative adenocarcinoma with the TTF, thyroid transcription factor positive. So that was suggestive of an invasive adenocarcinoma lung with the multiple metastases.
Nirmal, one
Yes, sir.
point.
Yes, sir.
Epidural collection or a tissue?
It was reported as epidural mass, sir.
The collection is different, mass is different.
It was reported as epidural mass, sir, not collection, sir.
Okay, right.
Okay,
Go
sir.
ahead.
So currently, patient is under palliative spinal artery, and chemotherapy is being planned after the radiotherapy is completed. So short discussion on spinal epidural metastasis. The most common tumor is CA lung, followed by prostate in males and CA breast in females. It's a more often a presentation of previously undiagnosed neoplasm. As in our case, we diagnosed the CA lung only after the patient had spinal complaints. So the mode of spread of spinal epidural metastasis is contiguous spread from the vertebral body, and also contiguous from the lung in case of Pancoast tumors. So the epidural abscess, epidural mass is known for stereotypical progression of symptoms. 90% of the cases have these symptoms typically, which is a back pain, radicular pain, weakness with sensory symptoms. So like in our case, it evolved in the same progression, same manner. One other point is that epidural abscess tend to have multiple sites of involvement, with other sites being asymptomatic. In our case also, we had a lumbosacral involvement, which was probably asymptomatic because patient didn't have any lumbar complaints. Signs are also not in favor of a lumbar root involvement. Only thing is this low limit, low tone, but reflexes are preserved, and bulbocavernous reflex was also, tone was normal, anal tone was normal. So treatment of epidural abscess is epidural mass or collection is with that corticosteroids with the daily dose of 8 to 100 mg of dexamethasone, and fractionated radiotherapy with 30 to 45 days in 10 to 15 days, including 1 or 2 vertebral bodies above and below the lesion. And if compressive myelopathy is there, surgery plus RT yields better results. And RT outcomes depends on functional status prior to initiation, but in our case, it was almost complete paraplegia before the patient was initiated on radiotherapy. So the outcome is likely to be poor for as far as the weakness is concerned, and patient is contemplated for palliative care currently. Thank you. Thank you, sir.
Has he improved with steroids?
No, sir. No improvement, sir. And post RT, he had almost 6 sessions of RT is completed, sir. Still no improvement, sir.
Thank you.
Thank you.
Thank you, Nirmal.
Yes. Thank you, sir.
Symptomatically, one point, symptomatically, after the RT, the patient's pain was reduced. So that was the one thing. So I want to ask. Yes, sir.
Lakshmi sir.
Yes, sir. And in fact, as Janmustaram said, the patient feels comfortable because his pain is reduced. So we were able to give some degree of palliation by doing a RT. The pain is released, but the neurological deficit remains the same.
Lakshmi sir.
Yes, sir.
Vijayan Besra. I'm
Yeah,
still intrigued. I'm still thinking about that discordance between reflexes and the tone. Previously, one of the way to increase the tone is to turn the neck to one side. Maybe you can ask him to turn the neck to either side and check the reflexes on both sides and see maybe an indirect clue to the vestibulospinal and reticulospinal tracts being spared.
Sure, I'll do that. We'll do that.
I don't know whether I'm right or not. Chuma just sudden.
No problem.
Non-writing,
Vijayan,
Sir, sir.
same thing. This tone is vestibulospinal and reticulospinal also, as you rightly pointed out.
Sir.
It is also the lateral vestibular and medial reticular formation, and everything will also contribute for the stretch reflector to maintain the tone.
Just an idea that தலையை ஒரு சைடு திருப்பி வச்சுட்டு check reflexes on both sides.
Lateral vestibular nucleus is a vesticulatory for this.
We can have an indirect clinical clue as to that the vestibular spinal reticular spinal.
Since upper limb is normal, hello.
Yeah.
Sir.
Since upper limb is normal, can we do this Gendrasix maneuver to?
This turning the head is also one of the Gendrasix maneuvers.
Okay.
Yes, sir. We will do that and then update you, Vijay.
சும்மா தோணுச்சு அவ்வளவுதான்.
இல்ல கரெக்ட். Definitely.
The turning side is chronic right ankle reflex. Yeah.
Sir, shall we go to the next case, sir?
Yes, please.
Sir, I invite Dr. Sujaya
Yes,
to
sir.
present the next case.
Sir, I'll share my screen.
Yeah, please.
Yes. So is the screen visible?
Yes.
Not the full screen.
Yeah, right.
Yes.
So, sir, shall I start?
Please.
Yes.
Go ahead.
Yes. Sir. Good afternoon, everybody. I'm Dr. Sujaya Raghavendra, final year resident. First of all, I would like to say thanks to everyone to give me this wonderful opportunity for presenting. This is my first time, so I hope I do a good job. So, starting with the presentation. So this is about Mrs. Rachel. Age is 38. She's a female. Occupation is a kindergarten teacher, and her educational qualification is diploma in economics, and she's a right-handed individual. So she came to us with complaints of fever for past 8 days, numbness of the right side of the forehead and the cheek for past 6 days, deviation of angle of mouth to the left side for the past 6 days, and swaying while walking towards the right side for the past 3 days. So she was doing well till 5th of August. She had gone to the school and where she works as a kindergarten teacher. And she had, so after she came back home, she had history of fever, which was high grade. And it was around 3:30 in the afternoon when she developed this first episode, which was associated with chills and rigors. She took a paracetamol and her fever subsided. After an hour, she had 2 episodes of vomiting, which was non-bilious, containing undigested food particles, which is non-projectile, and no blood staining was there. She didn't take any medications for that, and later it subsided on its own. So similar fever spikes were present for the next 2 days, especially in the evenings, and the highest recorded temperature was around 101 at home. But she only took analgesics for that. So on the 8th of August, when she got up in the morning, she had numbness involving her right forehead, extending till her immediate scalp and the right cheek. So there was no numbness involving the nasal or the perioral area or anywhere else in the body. She did her daily course and had her food in the morning and slept. When she woke up, she had noticed deviation of angle of mouth to the left and had difficulty closing her right eye. She had a glass of water and there was drooling from the angle of the mouth. Had difficulty in speaking clearly, but he was able to understand what others spoke. So with this, on 9th of August in the morning, she went to a local hospital for consultation, where she was diagnosed to have a right-sided Bell's palsy and was given some oral medication and eye drops for the affected eye and advised to review in 3 days. So on the 10th of August, her relatives noticed that she was swaying or she was leaning towards the right side while walking. She was not able to walk straight. But as soon as she sat down, there was no swaying. The swaying did not increase on moving into a dark room or increase on washing the face. There was no, the swaying didn't increase on these activities. And there was no history of falls. So, and there was no history of involuntary movements involving the hands or spillage of food. For these complaints, on 11th August, she went back to the same clinic where the doctor noticed that she had some, while doing an examination, she noticed that there was some restriction of eye movements, mainly on seeing to the sides. But there was no restriction on seeing up and down. the patient never complained of any blurring of vision or double vision. So an MRI brain was ordered and she was referred to RGH and she got admitted on 13th August. So coming to some of the negative history. So this was a very short history. So there was, in these 5 to 6 days, there was no weakness of upper or lower limbs, no twitching of muscles, no thinning of muscles. She was able to roll over bed, lift her neck above the pillow. She was able to perceive smell normally. There was no hearing impairment. She didn't give any history of ringing of sounds in the ears, no vertiginous sensation. She was able to perceive taste normally. She was able to take food into her mouth, able to mix food and make a bolus, able to swallow both liquids and solids without any regurgitation, no hoarseness of voice, able to lift her shoulder and turn head side to side, able to feel the fullness of bladder, was able to void completely, and there was no constipation or fecal incontinence. There was no shock-like sensation while bending her neck, girdle-like sensation, no cotton wool or pins and needle sensation. There were no behavioral alterations, no fall in sensorium or any episodes of loss of consciousness. And she also didn't give any history of rashes, bleeding manifestation, yellow discoloration of urine or eyes, loose stools or trauma. So coming to the past history, she's a known hypothyroidism on L-troxin supplementation, 75 microgram. And she has no relevant history of diabetes, hypertension, or any connective tissue disorders, epilepsy or trauma. She has been vaccinated with 2 doses of Covishield last year in December, and she didn't have any complications because of the vaccine, post-vaccination, and there's no contact history of tuberculosis. Personal history, she consumes mixed diet, bowel and bladder habits are normal and sleep and appetite has been normal. Menstrual history, she attained menarche at 12 years of age, and it is a regular cycle. Marital history, she's married for 8 years. The only history was significant was that she had a tubal pregnancy for which it was DNC was done at the same time. And for the infertility treatment, she has not really gone for a proper medication or consultation after the tubal pregnancy. So family history, she has 1 elder sister and she is healthy and both her parents have expired due to some natural disease, which she doesn't know. So coming to the summary, this 38-year-old female, a known case of hypothyroidism, came with acute onset progressive neurological disease, starting with high-grade fever, 2 episodes of vomiting, following which she had numbness involving the right forehead and cheek, with deviation of angle of mouth to the left, with difficulty in right eye closure, followed by right-sided swaying while walking and restriction of both eye movements sideways, which was observed by the doctor at the clinic. And the history spans for about 8 days. So at this point of time with the history, the possible structures involved may be the 3rd nerve, V1, V2 branch of the 5th nerve, the 6th nerve complex, the 7th nerve, the right cerebral peduncle, hemisphere involvement, or even the vestibular system. Sorry, I didn't mention that. And possibilities can be, it can be a vascular event, an infection, or a demyelination. Coming to the localization. So the first symptom, as we saw, was after the fever, was the right forehead and the cheek reduced sensation. So I would like to localize it to the V1 and V2 branch of the trigeminal nerve, which is the supraorbital branch of the ophthalmic nerve, or the maxillary branch, that's the V2 branch. And the sensory component of the trigeminal nerve being involved, mainly the main sensory nucleus, and a part of the spinal nucleus of the trigeminal nerve at the level of the midpoints. But it can also, because the spinal nucleus of the trigeminal nerve can also extend to the C1, C2 of the spine. So at the moment, it can be anywhere between the midpoints and the upper part of the spinal cord. Swaying towards the right can be because of the cerebellum and its connections or the vestibular system. But for the vestibular system, she doesn't give any other history of hard of hearing or vertiginous sensation or any tinnitus. So coming to, and she only had swaying while walking, that too without there was no swaying while closing of the eyes. So that unlikely the large fiber neuropathy is also not there. So coming to the restriction of the horizontal eye movements, which was elicited by the doctor, that she was not able to move her eyes sideways. That can be a bilateral PPRF or a 6th nerve complex involvement at the level of the, probably at the level of the pons. And the deviation of angle of mouth to the right and eye closure difficulty suggests the right-sided facial palsy, element type of facial palsy, which can be nuclear or fascicle, again points to the dorsal pons. So all these symptoms point towards an intraaxial lesion, and being an acute onset of presentation, I would like to keep a vascular event as a possibility, and the history of fever also points out to a infectious etiology.
1 minute, Sujaya.
Yeah, yes, sir.
Yeah, is there any history-wise, is there any oral ulcer or genital ulcer? Is there any ocular manifestation, any?
No, sir. I probed the history with her before this event. She has been absolutely normal. The only event which has been very significant was the pregnancy. But apart from that, the rashes, she had no rashes, no hair loss, nor any ocular symptoms, sir, before this.
Any history suggestive of any joint pain pertaining to the collagen?
No, sir. No, sir. No joint pain history, sir.
No apla?
No, sir. No, she has
Okay.
not been investigated for
Not
any
been investigated.
complaints. Yes, sir.
Because
Do you think it's intraaxial lesion or extraaxial lesion?
yes.
Sir, I kept it as a possibility of an intraaxial lesion because if we take the cerebellum and its connection, because she had some swaying towards the right. So at this moment, it points out at that, and then plus the horizontal eye movements being restricted. So I felt that it can be an intraaxial lesion at the moment, sir, because there is one long tract sign currently involved. So
What
that log tract sign?
so the cerebellum.
Cerebellum.
Yeah, cerebellum, sir. The cerebellar tract, spinocerebellar tract can be involved in this. So that's why I kept it as a intraaxial, probably an intraaxial lesion, sir.
So you want to keep both the options here,
Sir,
both intraaxial and extraaxial.
yes, sir, but I want to lean to
Examiner has given the clue, so take it.
yes, sir. Yes,
Yeah.
sir.
Justin,
Yes, sir.
Options.
what made you suspect of Beshe?
Because, sir, because this multiple cranial nerve involvement, and that way, if you are considering intraaxial with the fever, I have encountered a similar case, sir, 2 months back. The involvement
It could be a demyelinating illness also.
Yes, sir. Yeah, being an younger age group, we have to consider the demyelination, but the first possibility is vasculitis, second is demyelination, third is infective etiology, sir.
So vasculitis related to Beshe.
Yes, sir, possible.
That was your thinking. Okay.
Sir, I would consider the first episode of sarcoid.
Yes, sir. Granulation, sir.
Okay.
Yes, sir.
In fact,
Again, why sarcoid?
Because of the facial nerve palsy, multiple cranial nerve involvement, and there can be involvement of cerebellar connections also.
Yeah, multiple, there is not multiple. It's the same. 5, 6, 7. 5, 6, 7 with the cerebellum. So it almost points to one location if we want to localize. So it's not an extensive multiple cranial nerve involvement. Fairly focal. Sujaya, what do you mean by bilateral PPRF or sixth nerve? Because there was restriction on either side, is it? That is, we are assuming that.
Yes, sir, because both the sides, actually, sir, this was not observed by the patient's relatives or the husband. So when she went to this local clinic, the doctor saw her, and while doing a routine examinations, she observed that she was not able to look, her eyes were stationary and she was not able to look on both the sides. But the up gaze and down gaze were both normal. So with that history, I felt that the lesion must be on both the sides, sir, because the both conjugate eye movements have been, the horizontal conjugate eye movements have been affected.
Because that is the only one which is sticking out. Once you say it is bilateral,
yes, sir.
Then see, even an extraaxial lesion becomes rather less likely than an intraaxial lesion.
Yes, sir.
So that is significant. That is significant in the sense that's the only finding. Only point in the so-called examination by somebody else to suggest that this could be a bilateral and thereby an intraaxial lesion. Yes, Justin.
Sir, can it be a bilateral sixth nerve? Sujaya.
Yes, sir.
Sujaya.
Yes, sir.
Sir. இல்ல சார் நானும் அதான் சொல்லுவேன். I don't know how you localize only based on that alone, one point alone to be intraaxial. Because Varisia it has got the V1, V2, and then cerebellum, seventh nerve. So if such is the involvement, usually think of an extraction. Usually, only that one point.
See, that is Sujaya's
I
localization.
think should we rely too much on that history?
Exactly. What she is saying is, according to her, there was no horizontal movement, whereas vertical movements were there.
Yes,
But
sir.
So
that's
no
based on
horizontal
history.
movement on either side. That is her impression. Because of
That
which she says it is bilateral involvement.
That is based on history, isn't it? So should we
Yes,
rely too much
absolutely.
on that?
Absolutely, yes.
No, but
Limitations are
it is
there. Gross
Yeah.
limitation is there.
Yes,
Yes.
that's why I thought
I-
why we should rely too much on history at this point now. I think we should
move on.
take that over to examination and then verify.
For the sake of postgraduates, I would like to tell two things which has been already told. You should have listened to Professor VL. He was telling about the base. See, neurobase has a preponderance to involve the brainstem. That is exactly why Sir said the brainstem and its connections usually involved in neurobase. That's why Professor VN Sir said this. Second thing,
Justin pointed out to Beshe.
okay, what a neurobase or whoever is pointing. So the second thing is regarding the sarcoid. Sarcoid has a predilection for the vestibular system. Patient had vomiting and some degree of could be a vestibular, we don't know, and a seventh nerve, and it has a predilection of the adjacent other cranial neuropathies are well explained in. So that sarcoid was possibility which somebody said also is fairly good. But for the postgraduates, remember that these are all worthy points. You get so many good points during the discussion. And secondly, Sujaya had the advantage of having an MRI with her. That is why probably is inclined to keep the intraaxial with the in the presentation. That's what I thought. Anyway, we cannot rule out an intraaxial involvement in view of the bilateral horizontal movements restriction. Is a definite pointer towards an intraaxial pathology.
Okay, sir.
Balaji, you have anything to say, Balaji?
Yes, sir. Good morning, sir. So do we have to consider a Miller fissure at this stage of history, sir?
Yeah. Demyelinating illness. Yes. I mean,
Extraxial.
Sujaya, question is, do you consider a Miller fissure?
Yes, sir, because demyelination definitely should be considered, sir, because she has some restriction of eye movements along with ataxia. So definitely, like, we should keep that also in mind. So that's why I gave a initial differential diagnosis of a most probably a lesion of a vasculitis bar a demyelination, sir.
Infection.
Is the sensory involvement
Your
common
choice
with-
was vasculitis, infection, demyelination.
Yes, sir. Yes, sir.
Is the sensory involvement common with the Miller fissure? Like
No, sir. That is the
facial
only.
sensation?
Yes, sir. That's like the only thing which is against this, sir. Because
The numb cheeks and the involvement of the infraorbital and the supraorbital portions of the V1 and V2, are they described in Miller fissure?
so no, sir. As far as I know, sir, only internal ophthalmoplegia, ataxia, is that forms the triad, sir.
Okay.
Areflexia.
Yeah, areflexia, sir.
There are variants.
Okay.
in
Then we'll go on to the examination. Move on.
Okay, sir. So coming to the examination, patient is moderately built and nourished. Her weight is 68, height is 158 centimeters, BMI is 27.3. She's conscious, cooperative, oriented in time, place, and person. The vitals were stable. She's at the moment of when I examined her, she was afebrile. No pallor, ictus, cyanosis, clubbing, lymphadenopathy, or pedal edema. Physical examination, oral cavity was normal. There was no evidence of any ulcers, aphthous ulcers, or any other problem in the teeth. No thyroid swelling, tonsils were normal. Skin, no rash, ulcers, no hyperpigmented patches, no purpura, no neurocutaneous markers, no skeletal abnormalities. Her hairline was also normal. I'll show you the photo, sir. There was no markers for chronic malnutrition. Breast examination was normal, no peripheral nerve thickening, and single breath count was also normal. So higher mental function, she was, attention was normal, MMSE was 30 out of 30. So coming to the proper cranial nerve examination, the first cranial nerve was normal. Visual acuity was 20 by 50, which improved with pinhole. The fundus was normal. Color vision was normal. Coming to the cranial nerve examination 3, 4, and 6, there was abduction and adduction restriction.
Just 1 second, Sujaya. Sorry.
Yes,
Sir, Professor VN, sir.
Yes, sir.
Sir, I of late find quite a lot of neurological manifestations, young females around 30s and 40s with breast involvement, sir. And I think it's high time that we should stress that any neurological patient, woman patient who comes with neurological breast examination should be stressed by all of us. That's what I thought, because I found that most often it is neglected, sir.
Point taken, sir.
Thank you. I just wanted the forum, because all the youngsters are there. They should never forget the examination of the breast of a female in any neurological condition which they are presenting. That's I think that's it's worthwhile, because you will pick up some early cases. Thank you.
Only addition is, please see to that the female examines the breast, not we.
Okay. Thank you.
So coming to the extraocular movement, the abduction, adduction was restricted on both right and left, and the elevation and depression was normal, and it was not maneuverable. And this was on both the sides, both right and left. Pupil was 3 mm. The light reflex was normal. Accommodation was normal. She was able, convergence and accommodation was normal. Ptosis was not present. Saccades in pursuit, I couldn't test. And the VUR was only present in the vertical gaze. Coming to the sensory, for the fifth nerve, there was reduced touch, pain, and temperature. Actually, the finding was more for V1 than V2, but comparatively, like when I compare it to the left side, it was definitely reduced on the V2 also, like on comparing to the right. The power was normal for the motor examination for the fifth nerve. The corneal reflex and the conjunctival reflex was absent on the right side. So coming to the seventh nerve, forced eye closure was weak. Blowing of cheek also was weak on the right. Whistling she was not able to do, and the angle of mouth was deviated to the left. The eighth nerve was normal, and the vestibular system examination was also normal. 9th and 10th was also normal. Gag was present, and sorry, this was just a typing error. 11th, it was normal. 12th also, it was normal. So this is the image of the patient. So as we can see here, that she has a right-sided facial palsy, and she had difficulty in closure of the eye, and the nasolabial fold is also flattened on this side, and the deviation of angle of mouth is prominently seen to the left. This is the vertical gaze was normal for this patient, and this is the gait which I saw. Actually, when I examined, she was not having much of a gait disturbance as like elicited with the history, but definitely there was a tandem walking was impaired for her. So coming to the motor system, the attitude of the limbs were normal. Bulk.
But did you show the eye movements?
Yes, sir. I should should I show it again, sir?
Yeah, please, one second. Right, left, for right, left.
Sir, for right and left also, she was not able to move, sir.
Okay.
Not able to move. Yes, sir. So coming to the motor system, that was normal, sir, for the patient. Upper limbs and the lower limbs, both were normal. The abdominal and truncal muscles, there was no weakness. Neck weakness was not there. Coming to the superficial reflexes, the conjunctival and corneal was absent on the right side, and the plantar was withdrawal on the right side. There was some exaggerated reflexes on the right side, the biceps supinator and the triceps. The pectoral trapezius was also present. Jaw jerk was just present, but it was not exaggerated. Wattenberg and Hoffman was also present. Knee and medial hamstring was also present. Ankle was present, but it was no pronus, but there was some exaggerated reflexes as compared to the left on the right side. Sensory system, except the V1 and the V2, the rest of the sensory system was unremarkable examination. Coming to the cerebellar examination, the finger nose finger test was impaired on the right side with impaired tandem walking, but other examination was normal for her. Extrapyramidal system, autonomic system was all normal. Signs of meningeal irritation were absent at the time of examination, and vertebral tenderness was also not present. Gait was normal, but just that the impaired tandem walking was there. So other system examination was also normal. So summary after the examination. So after the examination, there was bilateral conjugate horizontal gaze palsy with a right-sided facial palsy, sensation of touch, pain, and temperature over the forehead. V1 and V2 area on the right side were also reduced. Her DTRs were exaggerated and the reflex level is above the pons. Also, she has right-sided cerebellar signs in the form of impaired finger-nose finger test and impaired tandem walking. So at this time, the final localization, I would like to keep it like a involvement of a bilateral PPRS, right seventh nerve, nuclear or maybe the fascicular involvement, the cerebellar connections, probably the pontocerebellar connections, the right trigeminal sensory nucleus, and the right corticospinal tract involvement. So probable location is that of a dorsal pons and the upper medulla to some extent. So
Sujaya,
yes, sir.
whenever the corticospinal tract is involved, that definitely means the ventral pons is also involved.
Okay, sir.
Okay.
Yes,
The ataxia component points towards the dorsal,
yes,
and the corticospinal tract points towards the ventral. So the involvement has to be both ventral and dorsal pons.
Okay, sir. Okay, sir. Fine, sir.
Jaya,
Yes, sir.
you said the corneal reflex.
Yes, sir.
What is the afferent? What is the efferent?
So the afferent is the fifth nerve and the efferent is the seventh nerve, sir.
Unilateral or bilateral?
Sir, actually, when we test for corneal reflex, it should be there is bilateral response on both the sides. But in this case, she had a palsy on the right side, sir. So
Afferent is involved on the right side.
Yes, sir.
Then what about the left side?
So left side was normal, sir. But again, the right side, I couldn't get the reflex for her.
Yeah,
because
that's
of the, yes, sir.
No, Sujaya,
Yes, sir.
when you did the corneal reflex, when you stimulated the right side cornea,
Yes, sir.
what was the response on the left side?
There was a blinking response on the left side, sir.
That means
So the
afferent.
afferent is preserved.
Yes, sir.
So it's only an efferent on the right side which is affected.
Okay, sir. Okay.
The right V1 is the afferent, Lapa.
Yes, sir. Yes, sir.
When you stimulated it on the right side,
Yes, sir.
did you get any response?
Sir, on the left, there was there was mild blinking, sir.
That means that right V1 is intact. Phi 1 is intact, not V1. Phi 1 is intact.
But the sensation was reduced, sir, on the V1.
Yeah, sensation was affected, but the corneal reflex did not show it.
Oh.
Corneal reflex wise, the right phi 1 was seems to have been intact.
Intact.
It's not corroborated.
This finding is to be verified. It is not possible.
Okay, sir. Sir.
When you have a seventh nerve involvement,
yes, sir.
can a person also say that there is numbness on that side? Does it happen? An element facial palsy.
Yes, sir.
Can it be associated with the subjective numbness or even objective numbness? Have you seen patients like that?
So personally, the sensation wise, usually it is normal only, sir. But in her case, like on repetitive examinations also, she couldn't feel anything on the forehead on the right side until almost till the scalp. but it was almost till the scalp, sir. And that
Okay.
was a presenting complaint of hers because it all started with that event.
So the ophthalmic division of the fifth was involved,
sir.
according.
Yes, sir. Ophthalmic division. Yes. So probable etiology, again, like it is a demyelination, primary versus secondary, and can be a vasculitis or an infection. Sir, actually, I would like to continue the presentation because her symptoms have been progressive. So, with your permission, if I can go to the, like, after admission, I just wanted to tell you what happened.
Go ahead, go ahead.
Yeah, yes, sir. So the routine investigations done initially, they were, the WBC count was 10,000 and HB was around 12.1. The sodium and potassium were normal. This initial CSF analysis, the cell counts, protein, glucose were all normal, sorry. And the CSF virology was awaited. The anti-MOG, anti-aquaporin 4, CSF, OCB were all negative. Gene expert has been awaited. And the profile of for the vasculitis and the ANA has been sent, sir. So this was the MRI which she came with this MRI only she presented to us. So this is a DWI image which shows hyperintensity in the dorsal pons, and this is the corresponding ADCC which shows the diffusion restriction. And this is the further images. I have highlighted it. The same thing is seen in the medulla also. The hyperintensity can be seen on the right side of the medulla, and the dorsal pons, almost the entire dorsal pons is also getting involved.
Bilateral.
Yes, sir, bilateral. So coming to the, this is the T2 flare. Flare also shows some intensity, but other parenchyma, brain parenchyma was normal, sir. This is the MRA and MRV, which was normal. And this is the T1 sagittal, which didn't show any hypointensity or any, the rest of the parenchyma was normal.
Left vertebral is normal?
Yes, sir.
I think it's hypoplastic, left vertebral.
Sir,
Yeah, right vertebral is hypo.
So right vertebral, okay. Yeah, this side, okay, sir.
Right, go on.
So, so this is the contrast image. The contrast also didn't show any significant enhancement in this patient, the initial contrast. So we admitted her, and in suspected demyelination, we started her on pulse methylprednisolone for 1 gram for 5 days, followed by oral steroids. So even after giving methylpred, she didn't... Yes, sir.
Diffusion restriction was there, no?
Yes, yes, sir.
அப்படியா சரி சரி வந்திருக்காங்களா வர சொல்லுங்கப்பா சரி சரி வர சொல்லுங்கப்பா அப்படி எங்க இருக்காங்க ஆத்தூர்லயா
Sir, yes, sir. Diffusion restriction was there, sir.
மாத்திரை போட்டுருக்கீங்களே போடும் ரொம்ப ஹெவியா டோஸ் போட முடியாது மைல்ல போட்டு அப்படியே ஒண்ணுமா சரி பண்ணுவோம்
Pani sir, can you mute everybody, please?
Please mute, please mute, please mute.
வந்துருக்காங்களோ வயசு எத்தனை இருக்கு இப்போ
Pani.
இப்படி வந்துருங்க இப்படி வந்துருங்க
The technical support team, can you mute everybody, please? Thank you.
Yes, sir. Yes, sir.
Yes, sir.
Please.
When there is a diffusion restriction,
Yes, sir.
what is your first diagnosis?
The first diagnosis is that of a vascular event only, sir, a stroke, because acute stroke should be kept in the mind, sir, as a first diagnosis.
Normally, do demyelination blocks have a diffusion restriction?
No, sir. Normally, diffusion restriction is not seen, sir.
Okay, go ahead.
Yes, sir.
Was there contrast enhancement?
No, sir. There was no contrast enhancement. I'll just show you the image. There was no contrast enhancement, sir.
Thank you.
Thank you, sir. So what happened after admission is that because we suspected demyelination, though like the initial report which was given outside was that of a chronic infarct involving the dorsal pons and that on the right medulla. But because of the history and the presentation, we thought of giving her pulse methylprednisolone, and it was started for 5 days, and that was later changed into oral steroids. So what? But even after that, there was not even there was no improvement, and the presentation remained static. So on the day 10 of admission, she developed some difficulty in swallowing for liquids and hoarseness of voice. This also while daily examination of while daily examining the patient only, we found it out, sir, because they themselves didn't complain, and she mainly complained of hoarseness of voice. But then when I asked that whether she had difficulty of swallowing, she had the difficulty. And when the examination I did again, so there was the palatal movements were normal only, sir, but the gag was absent.
Which side?
Sir, actually gag was mainly absent on the right side, sir.
Okay.
Right side gag was absent, sir. The left, it was just present, sir.
That lesion also explained that also.
Yes, sir. So then immediately the RT insertion was done. So here now the 9 and the 10 nerve was getting involved. So after this event, after 5 days, she was immediately shifted to the ICU because of these progressive symptoms. And after 5 days, she developed a right-sided upper limb monoparesis. So she had difficulty in her hand grip was reduced to 70%, and she had a slight difficulty in lifting her hand. Extension of the hand was wrist extension was weak. So this has progressed to right-sided hemiplegia, sir, for the last 2 days. And but the fever spikes have now reduced for the past 5 days. And since yesterday, the sensorium has decreased in the form that the response to simple command response is also reduced, and some gestural commands only she is able to follow. So yesterday only we repeated another MRI for this patient. So, sir, should I go ahead?
Yes.
Continue.
Yes, sir. So, so the MRI brain plane done yesterday showed there's some hyperintense lesion. This is the T2 flare coronal section, which shows the hyperintensity in the frontal region, sir, on the left side, on the right side, as we can see from this image. And
Right side or left side?
Sir, left side, sir, left side.
Wedge-shaped hyperintensity.
Yes, sir. So the diffusion restriction was also present, as I have shown it in this image, at the same area, sir. And the pons lesion also remains static. So there is no, not much of increase from the previous image, as discussed before. And the medulla also shows the same image of diffusion restriction is there, sir. The corresponding ADCC also has the the findings, and here also we can see the findings on the left frontal region. So this is the T2 image, and here also we can see the hyperintensity on the frontal region, and also as we can see here in the medulla, there is a hyperintensity in the medulla and the pons. This is the T1 sagittal. It is almost normal, so there is there's no hypointensity in that area, sir. So, sir, actually we have planned for an MRI contrast for this patient. Currently MRI contrast and the spine screening has been planned for this patient, and it will be taken today, sir, for this patient, sir. So with this,
These findings, what do you suspect?
Sir, because
Madam, can you please show the?
Yes, sir.
Can you please show the initial flare image again?
So the first MRI, sir.
The coronal image.
Yes, sir. The first one or the second one, sir? Now.
First one, coronal. You showed the
Okay,
coronal
sir.
image.
Yes, sir. Yes, sir.
No, the second set series only. You showed a flare image.
Yes, sir. Just this one.
This one. Yeah.
Yes, sir. So
Okay.
here is the lesion, sir. Like the left frontal, there's a lesion. Actually, the report which has been given is like acute infarct in the left frontal region, sir, with the dorsal pons and the medulla involvement. The right medulla involvement is there, sir.
Why do you say it's infarct?
Yes, sir. ADC, corresponding ADC, there is.
Sarah has given a clue.
Sir?
Ellen. Sarah has given a clue. Ellen sir has given a clue.
Yes, sir.
Why do you say? Why do you say it's an infarct? Can it be a demyelination?
Sir, because diffusion restriction with the corresponding ADC mismatch is usually like in
More
demyelination.
than that, the shape, ma, wedge shape.
Yes, sir, the wedge shape.
Wedge
Yes,
shape one is always invariably points out towards the
and vascular an
event.
infarct.
Vascular event.
So, sir, at this point of time, because the whole history spans for almost like 2.5 to 3 weeks with like static symptoms and with initially static symptoms and now progressive symptoms. So definitely, sir, the first thing which comes to my mind is that of with the on and off episodes of fever. So we should definitely rule out a vasculitis, sir, in this lady. And seeing the fact that she had a previous history of a tubal pregnancy and there is some and she has some secondary cause for that infertility. So, sir, I feel like at the moment we should work in terms of a vasculitis and seeing the aggressiveness of the disease, sir.
C and P and
P ANCA, sir. So currently the vasculitic panel is awaited, sir. So, but we have currently planned for a immunomodulator immunomodulation, sir, for this patient.
Why it is progressive? Different territories.
So that is the thing, sir. Like actually, it is first initially it was involving the brainstem. Now it is involving the other cortical region, sir. So the maybe, sir, I think we have to think about neuro-Bechet or ANCA variable vessel vasculitis or ANCA associated vasculitis, sir, for this patient.
See, it has got two territories involvement.
Yes,
Either
sir.
MCA1, second is an basilar one, second is an MCA1.
Yes, sir.
Okay, whenever what is triple territory sign or two territories, two different territories have been involved. If it is involved, you have to suspect associated paraneoplastic. Then, because the vasculitis, because it's a wedge shape, still a vasculitis is a first possibility. What is that? The cascade sign which is occurring in the neurobenign starts in one area, goes ahead from the midbrain or pons, it go ahead with the midbrain, then go to the thalamus. This is called cascade, slowly going up.
Okay, sir. Cascade sign.
So two things. One is vasculitis.
Yes, sir.
That is the main one. It's not a demyelination, still in a vasculitis.
Yes, yes. Still vasculitis.
Neuro-Bechet.
Neuro-Bechet. But sir, neuro-Bechet, other features are not there, sir, like the oral ulcer.
It's parenchymal and non-parenchymal. Two different entities are there.
Okay, sir.
Even a psychiatric manifestation also common. You can go for a B51, HLA.
Yes, yes, sir.
Or you can repeat the CSF.
Okay, sir. Okay, sir.
Sir Ellen, sir.
Yeah. My question, should we, it's an in-house stroke.
Yes.
Justin, what will you find in CSF and Bechet?
So there will be some pleocytosis will be there, sir.
Will be there, sir.
Yes, sir. In Bechet.
Mild elevation of protein and cell count will be there. And B51 will be positive, and it will be progressive, sir. It goes on from the brainstem to the upper end.
Sujay, you got some more slides to show. You are showing
Yes,
something like that's it. Yeah.
So the other possibility which I've kept in mind, I was doing a literature search for this presentation, is another is a COVID-19, sir. That is also, there are a lot of associations of COVID-19 infection, though it was like the RT-PCR showed some negativity initially in the testing, but the antibodies were positive. So such patients also present with a cranial nerve palsy and a progressive brainstem encephalitis like presentation. So there were two reports. One was in the BMJ, which I had seen, sir. And so COVID-19 being in a pandemic, so I think we should also keep infections like tuberculosis and COVID-19 also as a possibility in this case, but definitely not. I mean, lower down in the list, sir. I can give it as a differential diagnosis for this patient. And also the aggressive demyelination, which should be kept in mind, is a MOG disease. But like currently, there is no finding which involves the optic nerve. The initial VEP which was done was also normal, sir. So, and the imaging also didn't show any enhancement in the optic nerve.
The 2 episodes of diffusion restriction
Yes,
lesion,
sir.
which takes away the demyelination, is very unlikely.
Yes, sir. Oh, yes, sir.
For vascular.
Yes, sir.
And also the site of the second involvement, frontal lobe.
That's
Yeah,
very classical of a vessel involvement. So
Yes.
that's a subpile involvement, wedge-shaped involvement. So
Yes, sir.
that's very likely to be a vascular event.
Vascular event. Yes, sir.
So how about common source of a vascular event?
Sir, I
what,
don't.
sir, is
Anything in the heart,
anything that that's what embolic. Sir, is
heart, aorta.
So screening of the screening echo was done, sir, which is normal, sir, currently. The main echo has yet to be done. So screening done is normal, sir.
There is no IE.
ESUS. What is ESUS?
Endoscopic.
Endoscopy.
Not endoscopic. What are we discussing now?
Sorry, sir.
What are we discussing now? Are we discussing endoscopy?
No, no,
Common
sir.
source we said. So what should it be?
The carotid and the
No, what sort of a stroke should it be?
Embolic stroke of
Embolic
unknown
stroke, sir.
source.
yes, sir.
ESUS is embolic source of unknown source.
Yes, sir.
Okay. You have
Yes.
to investigate for embolism because 2 territories are involved. And secondly, as Professor Justin said, you should also keep a paraneoplastic as a manifestation because carcinomatous strokes can involve multiple territories. Okay.
Yes, yes, sir.
And embolic strokes can involve different territories. And
Yes.
so also vasculitis can involve any vessel. So yes.
The presence of headache and facial palsy and multiple territory stroke involvement points out towards embolism, but we should look in for a patent foramen ovale also.
Yes, sir.
Yes, sir. Yes. Yes.
Yes, sir.
Thank you. Thank you. Is there any other points, sir?
Sir, should I?
Yeah.
Continue.
Okay. So this is just to highlight the arterial supply of the brainstem. So as we can see that we can divide the medulla pons in the midbrain into anteromedial, anterolateral, lateral, posterior, and this is the source. So basically the pons, anteromedial is by the pontine paramedian arteries, and the anterior spinal artery is the anteromedial is by the anterior spinal artery. The anterolateral is the short pontine circumferential arteries for the pons, and mainly the pica for the anterolateral. And the lateral is the long pontine circumferential arteries and the ica. The posterior is by the superior cerebellar artery. And this is the main branch from which it arises. So this is just to highlight on the anatomy because whenever we see such cases, we should always keep in mind so that it's easier for us to localize. So, so this is the transection at the lower part of the pons. So here, so mainly the lesion I feel has extended till here. So this is the dorsal part and this is the basis pontus. So the peduncle, the facial nerve, the abducens nerve, all is getting involved, sir, and the corticospinal tract involvement is also there. So this is the same in the image, corresponding image, and so we can see the involvement of the dorsal tegmentum and the ventral and the dorsal tegmentum. So this is the same thing. Just highlighting the blood supply of the pons. So which is as mentioned, like the artery before. This is the medulla at the level of the olive, And here also we can see the structures which are getting involved in our case. The ninth and now that the 9th and the 10th nerve is also getting involved. So the vagus nucleus and the nucleus ambiguus has also got involved in this patient. So, sir, thank you for the presentation, sir.
Thank you, Sujaya, for excellent presentation.
Thank you, sir.
You should follow up and come out with the answer. What is going on?
Yes, sure, sir. Thank you, sir.
Yes, sir.
You continue, you conclude. Whatever comments is required from Shanmugh Sundaram, Ellen and others.
Yes,
If
sir.
there are any comments, you ask.
Ellen, sir.
Yes, sir. Sir, we'll, as you suggested, we'll work up for the embolic and the other vascular profile and update you as a brief couple of minutes presentation of what happened to this case in the next meeting, sir.
Yes, sir.
Shanmugh Sundaram.
I think that's already discussed very well by yourself and Professor Vivian and Ellen.
Sujaya, your presentation was very good, Sujaya. I should
Thank you,
compliment.
sir. Thank you, sir. Thank you.
Shall we conclude?
Sir,
Yes,
sir,
yes, Justin.
Sir,
Yes, sir.
Sir, you have become
Yes, sir.
very, very lenient on praising people, sir.
As age advances, that is what you would do.
And I can,
And
sir,
another thing I wanted to
as a student, I was never been able to satisfy your level. But
now, another thing I wanted to say is I wanted to congratulate all the professors of neurology in all government medical institutions and private medical institutions.
I concur with Ellen, sir. I could not satisfy you in my presentation as a student.
Wait a minute. I want to congratulate all the professors of neurology of the private medical colleges and the government medical colleges in the state for having produced 10% result in DM neurology examination. In all the colleges, we have achieved 10% result.
Sir,
yes, sir.
The level of compromise which you are making in quality of neuroeducation makes me apprehensive.
Yes, sir.
I think you have a valid point. But that is what is happening.
Yes, sir. And I don't know, but now you should have a lot of courage to fail a person. It has become like that.
Yes, sir.
Because nobody wants to get into litigation and all other things. In a highly litigatory world, in fact, the exams have become a formality, sir. Very unfortunate.
Looks to be so.
Yes, Ellen, I agree with you. Ellen, I agree with you.
Yes, sir. And very unfortunate, sir. But really, nobody. We are all at nobody has the courage to face all things. So things go. We just don't want to get into anything. Just leave it as it flows. Very unfortunate, sir. Anyhow, I think systems should become more objective in evaluation, more objective in evaluation than subjective, and that would really result in getting out good quality neurologists.
Lakshmi sir.
Yes, sir.
I think we should not fail any candidate.
Absolutely. That's absolutely. But the only thing which after 3 years of training, only thing I look at it is the community, whether they are safe to the community. That's the only thing which I look at. They can always embrace on knowledge. Knowledge is there throughout the life. They can update themselves. I don't look at any other thing except that they have the way to approach a case, and then are they community safe on certain essential life-saving emergencies. That's all. That's the only thing which I look in the exam.
Correct, sir.
Ellen,
Yes, sir.
there is
Yes,
one thing which I do not agree with you, and that is what you said about my assessment of you. You've
Yes, sir.
always been on the top. There's no question about it.
No, sir. That's all. Sir, you are an inspiration to all of us. I think if there is a way in which we can all give a standing ovation to you, in spite of at this age also, you are an inspiration to every one of the neurologists in the state and the country. My salute to you, sir. My salutes to you. I always look to you as as a source of inspiration, sir.
Thank
And,
you.
And
But that doesn't take away from my statement that you have always been on the top. Don't say I have not appreciated you.
you've
Cannot
always
be so at all.
no.
Sir,
You always
do
appreciate
appreciate you.
Not that.
Sir,
Not
ஒரு
that.
நிமிஷம்.
Sir, not that.
ஒரு நிமிஷம். Vijayan from Coimbatore.
Yes, Vijay, சொல்லுங்க.
தோ நீங்க டைரக்டா எக்ஸாமினர்ல இல்லைனாலும் நான் இன்னைக்கெல்லாம் கான்ஃபரன்ஸ்ல பிரசன்ட் பண்ணும்போது உங்க மூஞ்சியை பார்ப்பேன். நீங்க தலையாட்டிட்டு அப்படி குனிஞ்சிருவீங்க. யூ ஆர் நெவர் அப்ரிஷியேட்டட். அது
ஐயோ, பாருங்க. நான் தான் சொல்றேன். The most forward looking, the most aggressive management comes from Vijayan. நான் எப்பவுமே சொல்லுவேன் அது.
ஆனா
And the
உங்களை
points
பார்த்தா தான்
which you
எனக்கு
put
பயமா
forth
இருக்கும்
also.
எப்பவுமே. ஆனா உங்களை பார்த்தா தான் பயமா இருக்கும் எப்பவுமே.
Sir, even on Wednesday morning, sir, in Wednesday morning meetings, you are still a real source of fear, sir.
I don't know. I
In front
cannot
of your,
comment. நான் இனிமே Wednesday morning meeting வந்து பாப்போம். அப்ப சொல்லுங்க.
in fact, we all salute your academic brilliance, sir. Thank you, sir. Thank you so much. Thank you.
Thank you.
I think
Justin, நீங்க go ahead.
Yes, sir. I thank Professor Director Ellen sir and Shanmugam Sundaram for moderating this session. I thank Professor Vian sir for inviting me and elaborately arranged for this. I think still now we are learning from you, sir. We always learning many points from you, sir. Thank you.
Sir, everybody is learning from everybody, sir.
Yes,
Don't say that. Please don't say that. All of us know that everybody is learning from everybody. There are so many things which Nirmal Kumar pointed out and Sujaya pointed out. From their presentations, we learn so much.
Yes,
so everybody learns from everyone. And that is why we keep this program running. And
yes,
we get different inputs from
Justin, I learned one from you, the cascading form of the cascading.
Yeah,
events in
cascading.
the budget.
Correct.
It's a new learning for me. It's a wonderful experience. Basically, I salute to VN sir for arranging this program.
Yes, sir.
No, Justin is expert on Bechet. He has a number of cases of Bechet.
Yes, sir. Thank you, sir. Thank you for the supporting team of Sun Pharma for arranging this. Thank you once again.
Thank you, the chairpersons. Thank you, the presenters. Thank you, moderators. Thank you, the participants. And thanks to the logistic support provided by Sun Pharma. So we'll meet next time. Probably Sims will be presenting next week. Next month. Thank you.
Thank you, sir. Thank you, sir. Thank you.
Thank you so much.
Sir. Thank you.
Pani, நாங்க போலாமா?
Thank you, Shanmugam.
Yes, sir. Yes, sir. Yes, sir.
Okay. Thank you.
Please stop the recording. Yeah. Yes,
Thank
sir.
you.